Hello, everyone, and welcome to this audio podcast. In this intermission, surrounding the SupraTronix Intermission. This is the Shientist, and this will be sort of an intermission around a particular sort of immunological and sort of pathology sort of focused sort of condition, something that's referred to as myasthenia gravis. And once again, this is the Scientist, and this is part of a Storm Robotics production. So a bit of or introduction into this, and I suppose right appropriately so. This this To start off, I wanted to provide an overview in context of the sort of neurology bases that surround myasthenia gravis. So myasthenia gravis sort of has retrospectively been referred to as sort of a chronic autoimmune neuromuscular disease characterized by varying degrees of weakness or weakness around the skeletal or voluntary sort of muscles of the body in context of human physiology. And myasthenia gravis becomes sort of more severe with repeated use of muscle or during particular musculoskeletal and sort of physiology throughout the sort of the neurological bases that is affected through myasthenia gravis. And the name myasthenia gravis is Latin, which literally means grave muscle weakness. And with current therapies, or at least therapies that have been sort of documented, in most cases of myasthenia gravis are not as grave as the sort of the name implies. And so, in fact, the majority of individuals with myasthenia gravis, at least again, in context of the literature, life expectancy is not lessened per se by the disease or the disorder. However, and aligned to this, reflexes and sensory examinations around myasthenia gravis, at least again in sort of literature, have been documented as being quite normal. In around about 15% of cases that have been documented, there have been sort of weaknesses involved only in what's referred to as the extraocular muscles surrounding the eyelids, and this is referred to as ocular myasthenia. Now, in context of the sort of immunological basis, and in some ways, myasthenia gravis myasthenia gravis from a sort of pathology or a laboratory medicine basis versus for example, a clinical medicine or a medical perspective can be more intriguing. So, for example, from an immunology basis, immune mediated disorder, in which there are circulating sort of antibodies against the postsynaptic nicotinic acetylcholine or ACH receptors of the neuromuscular junction of skeletal muscles are evident. In aligned to the sort of immune mediated disorder aspects, there can be associated autoimmune phenomena referred to or have been evidenced as hypothyroidism, lupus, and rheumatoid arthritis, and vertigo. And so all these sort of autoimmune phenomena can be and have been evidenced aligned with myasthenia gravis, but again, but again, these particular autoimmune aspects are also a sort of a basis on their own in context of health, in context of health, aligned to particular immunological bases as well. And so the cause surrounding myasthenia gravis, at least in again in literature retrospectively, has not been had not been sort of transparent. However, IgG, immunoglobulin G antibodies to acetylcholine receptor protein, are identified, and alongside this, immune complexes. And so, for example, IgG and complement are deposited at the postsynaptic membranes, causing interference with and later destruction of acetylcholine receptor. And generally, when there's detriment to acetylcholine receptor, it is where for then example, there are issues around the neuromuscular junction, and the joining of so for example, where for example, in line with sort of nerves, and where nerve cells are connected, and also where that connection allows communication. If neuromuscular junction is sort of compromised or detrimented alongside the acetylcholine receptor, then generally that can then thus cause myasthenia gravis and myasthenia gravis like phenomena to be more problematic. So there is a sort of a histology and pathology basis around this as well. So from a histological point of view, myasthenia gravis is a disease caused by the formation, again, of antibodies to acetylcholine receptor on the sarcolemma in the junctional folds of the motor end plates, in aligned to in and aligned to the neuromuscular junction. And from a pathology basis, in adults with myasthenia gravis, the thymus gland is has been identified as being abnormal, and thymomas or tumors may develop as a result of that sort of abnormality. Generally, thymomas are benign, but they can become malignant, and thymomas derive from thymic, what is referred to as thymic epithelial cells, or spindle cell, or round types, sort of epithelial cells with an infiltrate of reactive lymphoid cells, and it's the lymphoid cells that actually cause more of the detriment alongside the neuromuscular junction aspect of myasthenia gravis, recipients or patients. And generally, the lymphoid cells contain certain clusters of immune cells indicative of lymphoid hyperplasia. So there's a growth around the lymphoids as well, and the condition is usually found only in the spleen, or part of the spleen, and the lymph nodes during the lymph nodes are active, become active during an immune response. So although so in literature it has been highlighted that although 80% of thymomas are benign, 20% of these lesions behave as low-grade malignant tumors as well. So generally speaking, whilst there is a general sort of evidence to indicate that the thymomas are benign, there is sort of that bases where at least 20% of the lesions that surround thymomas can be malignant based tumors infiltrating local structures with metastases, or can prompt metastatic spread in around 10% of cases with sort of mice with myasthenia gravis. In this context as well, from a histology perspective here, I'm taking this opportunity to include a histological sort of overview, where the axon foot, which in the sort of illustration, or the slide here, there's an AX. And the axon foot AX with mitochondria and smaller synaptic vesicles, which discharge acetylcholine into the narrow synaptic cleft, or the SC region. So in this slide, there is an AX side and there is an SC side, or region, and the acetylcholine receptors are concentrated or focused in the thickened muscle sarcolemma immediately beneath the AX part. And acetylcholine esterase is located deeper in the synaptic clefts, and contractile filaments are visible in the muscle cell, and in the lower right sort of region of this slide. Again, excuse me, from a a histological perspective, again, in this slide, there's a sort of a immunohistochemical staining, wherein there's a section of the thymus gland from one myasthenia gravis recipient or patient showing B cells expressing immunoglobulin M, or IgM, which is one of the main immunoglobulins as part of the immunological bases in sort of mammalian physiology, and also CD21 markers in germinal sort of centers. And here in this slide, you can see sort of you can see the sort of staining of the CD21 markers in this slide, where you can see there's sort of a sort of a thickened sort of red area in this immunohistochemical sort of staining in this slide. In this slide, there's a section of thymus gland from one myasthenia gravis patient showing B cells expressing CD23 in sort of in sort of germinal sort of centers. And here in the slide, you can see, you can hopefully see sort of a highlighted area where there is a general appearance of sort of almost semi-lucent or a luminescent area, which highlights the staining in context of CD in context of B cells being expressed through CD23 in this particular slide. From a excuse me, from an epidemiological perspective, the acquired condition, or myasthenia gravis, is characterized, or has been sort of characterized by weakness and sort of fatigability of proximal limbs. It is twice as common in females, in women, than it is in men, at least in according to literature. And ocular myasthenia gravis shows sort of a more predominance or preponderance in males versus females. Infertile juvenile forms have different causes, have different bases, if you like, than in adult cohorts. And the literature around the epidemiology retrospectively, the annual incidence is 2 cases per 1 million per 1 million. Although from an epidemiological basis, although that is evident, has been evident, there are conditions that are out there that I'm sure listeners will be aware of to some extent, that sort of almost give the impression of myasthenia gravis, but sort of have a sort of a bases from other sort of other sort of neurological perspectives, for example. And at the same time, prevalence of myasthenia gravis in the UK, in the United Kingdom, has been documented as 15 cases per 100,000 population, and the prevalence of myasthenia gravis in the United States has been retrospectively 14 cases per 100,000. The peak age incidence has been around 30 years of age. The thymic hyperplasia is found in around 70% of myasthenic recipients below the age of 40, and in around 10% of recipients, a thymic tumor can be identified, and incidence generally increases. The incidence around this generally increases with age in those recipients who have been identified with myasthenia gravis more particularly. In context of anatomy, the anatomy around myasthenia gravis is generally quite intriguing, but a few points here is to highlight is the disease or the condition is most commonly affects muscles that control the eye and eyelid movement. So the first symptoms that are noticed or noticeable are generally eyelid drooping, where there's eyelid drooping and or blurred or double vision, which is referred to as ptosis, diplopia. And many myasthenia gravis recipients start out with this from what is referred to, or what has been referred to as ocular myasthenia, and the majority will go on to develop a weakness in other muscle groups within one or 2 years. And in this sort of depiction, if you like, there's a sort of an overview in context of the eyes and jaw parts, the eye parts and the jaw parts that are affected in myasthenia gravis recipients. So there's a orbicularis oculi, which is the muscle that controls general eye movement, and then there's the masseter, which is the jaw muscle used for chewing food, for chewing. And in context of history, when sort of physicians look to identify patients or recipients who are suspect or are suspect for myasthenia gravis, these are this sort of slide provides a sort of an overview of the sort of the sort of the line of history, or the line of sort of history that physicians may use to identify more specifically in and around diagnoses. So, for example, what has the patient or recipient or other people noticed? When is the weakness most marked? After activity towards the end of the day, is there fatigue? Has there been double vision? Is there problems with speech, swallowing or breathing? Is there any history of other immune conditions? And is there a history of thymoma or thymectomy? In context of examination, the physicians generally would look to provide look to seek to sort of perspectives from sort of getting a perspective from for use for you in context of using these particular lines of sort of questioning. So, for example, is there any muscular weakness? And where there's to examine after repetitive movements, for example, the shoulder abduction. Examine eye movements and look for ptosis, diplopia and abnormal eye movements. Examine prolonged up gaze. Is the patient's or recipient's speech normal or weakening with prolonged or slurred speech? Ask the patient to count, where physicians can ask the patient or recipients to count up to 100. If there is any suggestion of respiratory symptoms or weakness, it is then important to assess respiratory function through particular investigations, and then use can do sort of an overview relating to fatigue fatigue on chewing as well. Some of the signs and symptoms, so for example, there can be respiratory difficulties that may occur. There can be ptosis, there can be diplopia, there can be fluctuating proximal weaknesses that can be identified. There can be muscle wasting, which is sometimes seen in myasthenia patients or recipients after years. After several years, for example, and there can be weakness in fingers, hands, neck, legs, and arms. In and around symptoms, there can be weaknesses identified in many muscles or muscle groups. There can be proximal limb muscles that are affected. There can be muscles of in and around speech, chewing, or which is referred to as dysarthria, and facial expression are commonly affected in early stages of myasthenia gravis. In and around the sort of investigations around myasthenia gravis, there can be sort of the neurological bases. There can be computerized tomography of the chest. There can be magnetic resonance imaging or MRI of the chest. There can be nerve stimulation as a way of to identify characteristic decrement decrement in the evoked action potential following continuous stimulation motor nerves. Of the motor nerves, and there can be single fiber electromyography or EMG can be quite helpful, and is generally sensitive in around 90%, but not specific, unfortunately, for myasthenia gravis entirely. So from a sort of an immunological basis, there can be a few investigations. So there's something that has been evidenced in literatures that's been referred to as the tensilon test, which is where there's short-acting acetylcholinesterase inhibitor, also referred to as edrophonium, which is administered while observing clinical effects on involved muscles. And in line with this, muscle-specific kinase protein or MuSK investigation can be used to detect and organize acetylcholine receptor on the muscle cell surface. From a biochemistry perspective, there's thyroid function investigations that are indicated to rule out associated Graves' disease or hyperthyroidism, and this is essential, especially in patients with ocular myasthenia, where the concomitant hyperthyroidism is frequent. A rheumatoid factor and anti-nuclear antibodies are indicated to rule out two main conditions that could compromise the clinical bases for myasthenia recipients, and that is to rule out systemic lupus erythematosus or SLE, and also rheumatoid arthritis or RA. From a pathology basis and a general pathology basis, more than anything, really, a muscle biopsy can be performed. However, generally, it's in literature, it's been documented as a sort of an investigation that's rarely performed. So from a pathology basis, in context of findings, So pathology shows a thymoma or a tumor of the thymus gland, and many others have thymic hyperplasia, where there's sort of a growth around the thymus gland region. Computerized tomography and magnetic resonance imaging can and should be performed in myasthenia patients or recipients. Studies of muscle biopsy specimens have identified at least in some contexts, that neuromuscular junctions, or NMJs of patients have only 1/3 of the average acetylcholine receptor found normally. From a hematopathology in context of morphology, so morphological or morphologic changes, such as sort of the simplification of pattern or of postsynaptic membrane folding, and an increase in the gap between the nerve and terminal and postsynaptic muscle membrane, are also, or have been identified. So findings from a neuropharmacology bases, excuse me, treatment, at least to an extent, for recipients with myasthenia gravis, is with anticholinesterase sort of based immune therapies. Retrospectively, pyridoxostamine, or a drug that's been referred to as, or branded as, mestinon, is a long-acting cholinesterase inhibitor with onset action beginning around 30 minutes post oral administration, and duration. The duration is around or up to 2 hours. 2 hours for pyridoxostamine to take it to cause the appropriate actions. And doses should not ordinarily exceed about 120 in around 120 milligrams every 3 hours. Anticholinesterase can worsen muscle weakness at the same time. So pyridoxostamine has been in literature has been identified as being prescribed 60 milligrams orally, and is sort of the sort of excuse me, is the sort of evidenced and documented dosage for this particular drug. And duration is around 3 to 4 hours for it to from a pharmacokinetic basis for pyridoxostamine to actually take its sort of action. There has been some evidence in the literature that other sort of drugs or medicines work. So, for example, corticosteroids can be helpful. There is an improvement in around 70% of cases, although this may be preceded by an initial relapse as well. General pharmacology. So certain medications can exacerbate symptoms of myasthenia gravis as well, and these can include antibiotics, particularly those that fall into the sort of aminoglycoside based formulations, narcotics as well, some penicillins, magnesium, anesthetic or anesthesia type agents, muscle relaxants, and also drugs are used to treat particular sort of heart conditions, or where there can be arrhythmias evident. Some challenges, and this is the last sort of slide I'm gonna provide here in this slide set. So the challenges is generally is essential to rule out mass lesions compressing the cranial nerves in strictly sort of ocular myasthenia gravis. A CT scan or MRI of the brain, a CT scan or MRI of the brain, and the sort of the sort of orbital area is in literature has been evidenced to be prompted or indicated. Systemically, myasthenic crises is perhaps the most dreadful complication, where sort of alongside the myasthenia, there can be complications around the heart as well. Aspiration pneumonia may also occur due to poor oropharyngeal muscle function in myasthenic recipients. Cholinergic crisis may follow excessive treatment with cholinesterase inhibitors as well. And ophthalmologically, a common complication is or can be cataract formation due to where in sort of in myasthenic gravis patients, there can be a sort of a chronic steroid intake owing to controlling some of the other sort of complications sort of that are part of the myasthenic gravis sort of neurological sort of disorder and disease. So that ends this particular audio podcast around this intermission, the SupraTronix Intermission. And this on this slide, I just want to acknowledge a colleague, Dr. Sarah Johnston, as a consultant immunologist at the Royal United Hospital in Bath in the United Kingdom. And just to acknowledge that colleague who had provided a sort of a basis around sort of myasthenia gravis in and around 2000 and between 2000 and 2004, between 2004 2006. So to acknowledge Dr. Sarah Johnston in this particular slide. So once again, thank you for taking the time to listen in on this audio podcast on this intermission. This has been another Storm Robotics production, and it's been the Shientist. Thank you.